Hi, my name is Brian Carey, VP of Marketing here at Unbound Medicine. Welcome to today's webinar, where Dr. Christopher Hoffmann will discuss frequently arising topics in HIV primary care to empower healthcare professionals with the latest clinical strategies. Dr. Hoffmann is an associate professor and clinical scientist in the Division of Infectious Diseases at the Johns Hopkins University School of Medicine. Dr. Hoffmann's research is focused on HIV diagnosis and care delivery to marginalized populations, primarily in Southern Africa, and he has been funded by grants from the NIH, the CDC, and the Bill and Melinda Gates Foundation, amongst many others. He is a key contributor to the Johns Hopkins Pocket, HIV, and ABX Guide apps, both of which are published and distributed by Unbound Medicine. Use the QR code on your screen for a free trial. Dr. Hoffmann will be answering questions live following the presentation, so please type in the chat or the QA box any questions you have at any time. I'll turn it over to you, Chris.
Thanks so much, Brian, and welcome to this presentation on some updates on HIV management from the past year. HIV continues to be a rapidly evolving field with lots of new innovations. So this is just touching the surface of some of the topics that I find most relevant to my clinical practice. I'm going to briefly talk about some oldies, that is when to start and what to start, and then get into the very rapidly evolving field of antiretroviral therapy and weight gain, mention a little bit about switching regimens and especially long-acting antiretroviral therapy, and then close with talking about cardiovascular disease risk reduction, and especially the results from the recently published and presented Reprieve study. So when to start has really not changed in the last decade, but there is increasing evidence that same day or at least very rapid ART initiation has both public health benefit in reducing risk of transmission, as well as medical benefit to the individual with less metabolic and immune injury from uncontrolled viremia, even with short durations of delay to antiretroviral therapy initiation. There have been multiple studies, mostly from low and middle income countries, in comparing randomized groups of individuals to delayed initiation or immediate initiation, and far more observational studies and translational studies from the United States demonstrating the benefit of early antiretroviral therapy initiation. And most recently, studies that I will not go into have shown that it is even feasible in individuals who are often considered harder or more challenging populations to assure adherence with, including those who are unhoused and those with substance use disorders. And those populations with the appropriate wraparound services can successfully be managed on antiretroviral therapy and can successfully have rapid antiretroviral therapy initiation. I've just included the DHHS guidelines recommending initiating ART immediately, and also acknowledging that strategies may be needed to optimize care engagement and adherence. I'm going to move on to what to start, and that has also remained fairly stable over the last few years. All the preferred regimens include an integrase strand transfer inhibitor, or INSTI. There's the fixed-dose combination of bictegravir, tenofovir, alafenamide, and emtricitabine, and the two-pill combination of dolutegravir plus either TAF or tenofovir disulfonyl fumarate, otherwise known as TDF, plus either FTC or 3TC. The two other preferred regimens both have a caveat that laboratory test results are needed before starting therapy, which means that if it's for same-day therapy, these regimens may be suboptimal. And the first is dolutegravir, abacavir, and 3TC, which requires HLA-B5701 testing and demonstrated negativity prior to initiation to avoid increased risk for abacavir hypersensitivity syndrome. In addition, 3TC is a suboptimal agent alone for hepatitis B co-infection, and thus this is not an ideal regimen for individuals co-infected with hepatitis B. There continues to be ongoing concern about a back of ear and increased cardiovascular risk, especially for those individuals at highest risk for cardiovascular disease. The fourth preferred regimen is two agents in a single tablet, dolutegravir and 3-TC. This is a acceptable regimen for initiation, except that it is less effective in individuals with very high HIV RNA, that is greater than 500,000, and also has the limitation that it's not so effective against hepatitis B. Thus, testing is needed before starting either of these. Finally, there remains a place for boosted protease inhibitors as a first-line regimen, specifically in individuals who are using cabotegravir long-acting as PrEP and have a breakthrough HIV infection. So INSTI resistance can develop in a breakthrough infection. INSTI resistance to cabotegravir occurs more frequently than to either bictegravir or dolutegravir, but there's cross-resistance with cabotegravir resistance and bictegravir and dolutegravir. Thus, INSTI genotyping is important in the setting of a breakthrough infection while on cabotegravir long-acting, and thus the preference for using boosted darunavir in this setting. I've listed these what to start regimens because it gets into questions about weight gain and ART regimen. And there have been questions about whether INSTIs cause weight gain, whether TAF causes weight gain, and whether there's a role for switching agents in terms of weight management. Over the last several years, there have been a number of observational studies suggesting that switching to an INSTI was associated with an increase in weight. A few years ago, the ADVANCE trial was published. This is a study of ART-naive individuals conducted in South Africa. There were 351 participants per arm in 3 arms, comparing 3 regimens. One, efavirenz, TDF, and FTC, the standard regimen in South Africa at the time, dolutegravir, TDF, FTC, and dolutegravir, TAF, FTC. The reason for including TAF was to compare toxicities, specifically kidney injury, between those receiving TAF and those receiving TDF. There were many important findings from the study, but one was the difference in weight gain by antiretroviral therapy regimen. And you can see in the figure here in orange is the dolutegravir TAF FTC, blue the dolutegravir TDF FTC, and green the efavirenz TDF FTC, and a considerable difference in weight gain at 1 year by regimen. The individuals who gained the most on the dolutegravir TAF gained on average 6.4 kilograms over that first year on antiretroviral therapy, compared to 1.7 kilograms among individuals on efavirenz, TDF, and FTC. Now, some weight gain is expected after starting antiretroviral therapy. Untreated HIV is associated with increased metabolic activity and catabolism. And in fact, one of the reasons that HIV at one time was referred to as slim disease or wasting disease. However, the considerably higher amount of weight that was gained among those on dolutegravir and TAF led to considerations that perhaps either dolutegravir or TAF, or perhaps both, given it was in that combination arm with the most weight gain, were actually promoting weight gain. Partly to test that, in a follow-up study called CHARACTERIZE, individuals who were in the ADVANCE trial at 192 weeks were switched to the current South African standard therapy of dolutegravir TDF and FTC. And among those who had been on dolutegravir TAF, especially women on dolutegravir TAF, within 1 year, there was actually average weight loss of 1.6 kilograms, suggesting that the TAF element may be promoting weight gain, or the TDF element may be promoting weight loss. So if we move on to that question about weight loss promotion or weight gain promotion, if we look back over 10 years to the IPREX trial looking at TDF FTC versus placebo for PrEP to prevent HIV infection, there was a difference in weight gain among those on placebo versus those on TDF FTC. In fact, those on placebo gained more weight than those who were receiving the TDF FTC. An early suggestion that TDF actually may lead to less weight gain or even weight loss for some individuals. We fast forward to just a few years ago, the Discover trial was completed, and that compared TDF FTC to TAF FTC for also for PrEP. And you can see in this study that among individuals on TDF FTC, there was on the figure on the right-hand side in the gray line, essentially no weight gain over 48 weeks, compared to the TAF FTC arm, where there was weight gain of a kilogram or so. Very similar amount of weight gain as was seen in the placebo arm of the IPREX trial. So this suggests that perhaps TAF is weight neutral and TDF actually suppresses weight gain or can even mediate some weight loss. These findings have created a lot of interest in seeing whether optimizing the ART regimen can lead to improved metabolic and weight parameters. And there have been a number of switch studies. I'm going to discuss briefly a few of them. One of them is the SOLAR trial, in which individuals on an INSTI and TAF, bictegravir and TAF FTC, were switched to cabotegravir, another INSTI, and ripivirine long-acting injection, so dropping the TAF element. 670 participants were randomized to either continuing the bictegravir or TAF or switching to the cabotegravir ripivirine arm. And in that study, at 12 months, there was no difference in BMI between those individuals who continued the INSTI-TAF regimen compared to those who switched to the INSTI without TAF regimen. Another switch trial, this time called the DEFINE trial, this time switched from an INSTI to a boosted protease inhibitor or boosted darunavir, keeping the TAF in both arms. Really looking at the question of whether in the INSTI itself and removing the INSTI could affect weight. This study enrolled individuals who had gained at least 10% of body weight on an INSTI. And among the 103 participants randomized to either switching or remaining on the INSTI regimen, the median age was 45 years and the median BMI 32.7. And by 6 months, you can see on the figure on the right, there was no difference in weight. In fact, there was perhaps a slight increase among the darunavir treated individuals, but wide confidence and overlapping confidence intervals. So in summary, current findings suggest that TDF leads to some weight loss. I didn't present the studies on efavirenz, but especially among efavirenz slow metabolizers, those that tend to have the most symptoms from efavirenz, most efavirenz adverse effects, there is also some weight loss. While with these other agents, that there's a concern that they may promote weight gain, there's now a lot of question. TAF seems to be weight neutral. Whether dolutegravir and bictegravir lead to any weight gain remains a question. Cabotegravir as well, suggestion that it does not lead to weight gain. And boosted darunavir also, whether it's weight neutral or leads to weight gain, is a question. So this gets to considerations for switching and whether there's a role for switching for weight management. So I'll first say that side effects are certainly a reason for switching, and there's almost always a regimen that can be found that will not have side effects if an individual is suffering from side effects from any of the preferred primary regimens, whether those side effects are insomnia, headaches, GI disturbance, or otherwise. But when it comes to weight gain, at this time, we don't have clear evidence of a regimen to switch to, nor evidence that the current regimen is necessarily promoting weight gain. The one agent that could be considered for weight loss is TDF, but given the kidney and bone effects of that and the perhaps marginal effect on weight, this is right now certainly not the practice or recommended in the United States or Europe. In addition, there are more effective weight loss agents currently available. The third reason for switch is convenience. And from a pill form, it's hard to get more convenient than one pill once a day. But switching to a once every 2 months injection can be more convenient. And there's certainly a growing body of evidence that cabotegravir plus rilpivirine, long-acting, every 2 months injection is widely accepted, is preferred by many individuals living with HIV, can reduce some of the psychosocial stresses of living with HIV, and improve overall quality of life. Notably, currently the FDA labeling is for virologically suppressed individuals. However, a body of research is being assembled demonstrating the effectiveness in achieving suppression in individuals who are struggling with oral therapy. And hopefully in the near future, there'll be more availability and more insurance coverage of this injectable regimen for that group of individuals. I'm going to finish with cardiovascular disease reduction and specifically the Reprieve study. We've known for a very long time that there's an association between living with HIV and cardiovascular disease risk, especially among individuals who are not receiving antiretroviral therapy. So certainly addressing modifiable risk factors is the starting point for reducing the risk of cardiovascular disease. And that includes antiretroviral therapy, cessation of tobacco use, managing hypertension, managing obesity, exercise, and managing hyperlipidemia. There's also a consideration that statins have a role beyond LDL lowering, and that's the pleiotropic effect of statins on a variety of pathways that can affect atherosclerosis. And that's inflammatory, thrombotic, immune, oxidative stress, endothelial function, and plaque stabilization. So the Reprieve study sought to test whether using a statin in a group of individuals who did not meet standard cardiovascular disease lipid thresholds for statin use could reduce cardiovascular disease. And the study team used pitavastatin, partly because of the minimal drug-drug interactions, and a moderate dose statin, and compared that to individuals receiving placebo. All participants at the time of enrollment were considered to have low to moderate risk for cardiovascular disease based on their 10-year cardiovascular disease risk score. And you can see among the nearly 8,000 participants that were followed up to 8 years, at the second to last row on the bottom, the cardiovascular risk score. And the median was 4.5% risk of major cardiovascular disease in the next 10 years, with 75% having 7% risk or less. So the vast majority of these individuals would not even be in the consideration of a conversation about statin use according to current lipid lowering guidelines. If we jump right to the primary outcomes, primary outcome was a major adverse cardiovascular event, or MACE. And you can see over 6 years a separation between placebo with more events and pitavastatin with fewer events, and already seeing separation between those lines by 1.5 years after study entry. There are a few important things to point out here. First, although this was a low-risk group, in the placebo arm, 4.3% of the individuals had a major adverse cardiovascular event. So a fairly large number over 6 years actually experienced an event. And the second important thing is that pitavastatin reduced that event with a hazard ratio of 0.65. So it was very effective in reducing the risk in this low-risk population for a cardiovascular event. If we look at pre-planned subgroup analyses, we can get perhaps a better idea of who may benefit the most. And you can see in the top line the overall risk and hazard ratio of 0.65. Then it's stratified by cardiovascular disease risk score. Those with the lowest risk, 0.0 to less than 2.5, had fairly few events in a very wide confidence interval, but still more events in the placebo, 17 compared to in the pitavastatin arm of 9. Those with slightly higher risk, 2.5 to less than 5%, had more events. Again, confidence interval crossing 1, and actually the effect size suggesting increased risk for placebo. But again, wide confidence interval and crossing 1. I think most importantly, those with a risk score of 5 to 10%, many of whom would not currently be suggested to be started on a statin, had about a 50% or 52% reduction in the risk of cardiovascular disease with confidence intervals that did not cross 1. You can see some of the other subgroup analyses and looking on the manuscript itself, additional subgroup analyses. But I think for me, the take home here, and I expect that guidelines for cardiovascular disease risk reduction among people living with HIV will extend the indications for statin use to individuals with a cardiovascular risk score of 5% over the next 10 years or higher. So in summary, INSTI regimens are generally preferred as initial regimens. It remains unclear whether INSTI agents promote weight gain, but it does not appear that switching from an INSTI is an effective way to manage obesity. TDF appears to promote weight loss, but because of its various adverse events, including kidney and bone, it is generally not considered an ideal weight loss agent. There are preferred weight loss agents currently available. TAF appears to be weight neutral and not promoting weight gain as initially suspected. And thus, there's really no clear ART switch option to reduce weight at this time, although there are additional ongoing studies. Cabotegravir, Reprieve long-acting is an excellent option for the right patients. And we should probably extend the criteria for statins among people living with HIV. I hope you found this interesting and either confirmed current practice or shed light on additional topics. And I wish you well in your journey in improving the lives of people living with HIV. Thanks so much. Now we have some time for some questions, and I welcome further discussion of any of these topics.
Hi, everyone. My name is Brian Carey. I'm from Unbound Medicine. Just wanted to thank everyone for coming on to today's webinar. And we do have an opportunity to answer some questions from Dr. Hoffmann. So, Dr. Hoffmann, thank you for joining us today and for giving us that outstanding presentation.
Sure. Yeah, my pleasure, Brian.
So we were able to get a couple of questions in. So the first one would be, how do you integrate the Reprieve study into your clinical practice?
So certainly a great question. We're waiting for some update and guidelines, but I would say the number one thing is I have some patients who are a little hesitant or have been hesitant to start statins. And this provides additional data to discuss with them in terms of the protective benefit of statins, even in individuals who are at relatively low risk. And certainly all of my patients who are with a cardiovascular risk score of greater than 5% risk over the next 10 years, I bring up the discussion with, at this point, whether or not they will agree to start them. At least the discussion has started to address risk modification with statins. And then clearly addressing any other risk modification, including tobacco use, hypertension, and obesity, and lack of exercise as a comprehensive package to reduce cardiovascular disease risk. And Brian, you're on mute.
Do that all the time. We do have a question from Sunny, which was one of the attendees today. So thank you for that question, which is, which other statins are compared with, and I may not pronounce this completely correct, pitavastatin?
So the Reprieve study chose pitavastatin because of its minimal drug-drug interactions and just general profile. But that's the data we have on pitavastatin. The pleiotropic effects of statin is believed to be a class effect and not pitavastatin specific. So I certainly, for a variety of reasons, have not tried to switch patients to pitavastatin. Other statins are off patent and are lower cost because generic formulations are available.
Fantastic, thank you. And we did have one more question, and it would be, would you consider switching a patient with weight gain to a TDF-based non-INSTI regimen, such as doravirine and lamivudine and -TDF?
So good question, and there's a ACTG clinical trial for a switch to doravirine, TDF, and lamivudine. I would say the current data would not necessarily favor that, and just secondary analyses of a number of the registration trials for doravirine, Drive Ahead and Drive Forward, have compared doravirine to individuals who are in the doravirine arm to the comparator arms, either efavirenz or darunavir. And for individuals who were receiving efavirenz, there was a more weight gain among those on the doravirine in the first year, I believe, but by 2 years, the weight, there was similar weight. And with boosted darunavir, there was really no difference between the doravirine and the boosted darunavir. So I don't think that a switch of ART right now is indicated or suggested, supported by the current evidence. And there are certainly more effective weight loss approaches that are best managed with a weight loss expert, but that certainly are more likely to provide benefit than any antiretroviral therapy switch. And if somebody has well-tolerated antiretroviral therapy with an undetectable viral load, maintaining that is generally the best approach.
Fantastic. Well, Dr. Hoffmann, that's all the questions that we had for today. Just wanted to thank you again for taking the time out for the presentation and to answer these questions. I want to thank everyone that participated in the webinar for taking time out of their day. I know their time is extremely valuable, so really glad they were able to carve out some time. Also want to remind everyone that a copy of this recording will be sent to all registrants as well as attendees. So you'd be able to take advantage of all the great information you heard today. In closing, Dr. Hoffmann is a contributor and author of the Johns Hopkins Pocket HIV Guide, as well as the Johns Hopkins Pocket ADX Guide. So please, if you're interested in those two guides, they're available as an individual subscription as well as institutionally.
So you can find them on your app stores. And if you have any questions, please reach out at webinars@unboundmedicine.com. If you have any additional questions, we'll be able to get them to Dr. Hoffmann. Again, thank you so much, Dr. Hoffmann. Have a great day, everyone. Thank you so much.
Thank you. Take care.